work in the Tampa and the St. Pete offices. Originally from upstate New York, trained in PM&R and did a fellowship in this stuff because I loved it so much. And yeah, excited to talk to you a little bit more about it today.
Awesome. My name is Dr. James Lieber. I founded New Regeneration Orthopedics quite a number of years ago and been part of Regenix for 13 years almost, I believe, and been involved in this field for quite some time. Trained in the Air Force originally, with some additional training after. And we have 4 clinics that we love doing what we're doing, and we're going to talk to you about shoulder pain today. And let's get going, I guess.
All right. And there, last and certainly not least, Dr. Pappas. Want to give a brief introduction and kick it off?
Sure. Actually, my 6th anniversary with Regenix Tampa Bay is coming up next week, I think. So I trained physical medicine and rehabilitation in Charlotte, North Carolina. And then afterwards at Interventional Orthopedic Foundation courses, mostly out in Denver. And then joined this practice 6 years ago, and this is 100% of what we do, treating people with regenerative type solutions and complex interventional procedures.
All right. Kick it off, Dr. Pappas.
Sure. So let's talk a little bit about the shoulder today. Let's go to the next slide. So the shoulder is okay, go back to the other side. I thought we unhid the next slide. So the shoulder is a little bit complex and a little bit simple at the same time. Shoulder is basically there's generally 3 things that tend to be wrong with it. And those 3 things tend to either involve the rotator cuff, which is a collection of tendons that come together at the shoulder to stabilize and move the shoulder. There's something called the shoulder labrum, which is basically a piece of fibrocartilage that allows for purchase of the ball of the joint into the socket of the joint. And then there's the joint itself. And so typically when we see shoulder pain, it's usually either an issue at the rotator cuff, the collection of tendons, an issue at the labrum, at the joint, or an issue with an arthritic joint. And depending on what those issues are, typically the algorithm that you get when you go to the orthopedic surgeon or typical sports medicine physician is something like physical therapy, corticosteroid injections, or surgery. Now, physical therapy, as a physical medicine doctor, you'll never hear me say that physical therapy is a bad idea. But there are some issues with corticosteroid injections and certainly surgery in either of those treatments that patients should be aware of. Next slide. So cortisone injections, they're okay in the short term in terms of reducing patients' pain, but they are toxic to tendons. They're toxic to cartilage, and they can increase the size of a tear. If somebody has a tendon tear, they can increase the rate of arthritis if somebody has arthritis in a joint as well. They have a number of other side effects that are not so great in terms of overall health as well. But especially if somebody gets into a habit where, okay, you do a steroid injection into their shoulder, it gives them 6 weeks of relief, they come back and get another one and another one. Chances are, you're making worse whatever problem, whether it's arthritis or a tendon tear. That is probably worsening over time as you inject it with something that is known to break down tendon, muscle, and cartilage. Next slide. And then let's talk a little bit about surgery. So the thing to know about shoulder surgery, first and foremost, is that it is not for the faint of heart. It is typically a pretty involved, painful recovery. 6 months at the on the very early side, on average. When I talk to patients that have recovered from an arthroscopic rotator cuff surgery, typically it's a solid year of recovery, where you're in physical therapy most of that time, and usually immobilized for 6 to 12 weeks after the surgery. Um, the other issue with the surgery, though, is that a lot of times it doesn't produce the long-term results that we'd like it to. Um, from the journal Arthroscopy, where they looked at a meta-analyses of 18 different papers involving almost 1,000 patients, basically it showed that 79% of the time, between 2.5 and 4 years later, that rotator cuff tendon that was repaired surgically was actually torn. Another study out of the Journal of Bone and Joint Surgery showed um, that just 6 months after surgery, depending on the age group, especially in those in more advanced age groups, 34 to 25% of patients over 70 years old, it was already torn within 6 months of surgery. And that's typically because when we're thinking of a rotator cuff tendon that's torn, most of the time it's a situation where the tendon degenerates first. And so what you're doing surgically is you're taking a degenerated tendon and then basically pinning it down onto the bone back in place. But if the problem is the degenerated tendon and you just alter it and pin it back down, the chance of that tendon tearing again is pretty high, as you can see from these studies.
And if you don't mind,
Slide.
if I chime in for 1 second,
Yeah.
Dr. Pappas, I've heard that described and seen that in surgical procedures described as essentially wet spaghetti. You're trying to pin down a really wet piece of spaghetti that is very, very just tough to pin down and very, very friable.
I usually tell people, it's like try and picture sewing up a piece of wet paper towel. There's nothing really to grasp, right? So it just breaks apart.
Yeah, exactly. All right, next slide. So there is a very common surgery done throughout the world, I should say, for shoulder impingement. So shoulder impingement is typically part of a rotator cuff problem, where sometimes the bones that are surrounding the rotator cuff can actually pinch it, especially while the rotator cuff is moving through particular motions. Usually it's going into an overhead position. And so there's a very common surgery done where they remove a piece of one of those bones to try to give the rotator cuff more room. The data, though, in the last few years that have come out, this study was from 2019 from the British Journal of Sports Medicine, showed, though, that when you compare people who've had subacromial decompression surgery for this type of condition with patients with either placebo surgery, meaning they put the patients to sleep and didn't actually do the surgery, or versus exercise therapy, there did not seem to be any benefit to those patients who underwent the surgical procedure. And obviously, anytime you go into surgery, there's a certain risk associated with that. Next slide. And then the last study I think that we have on surgery here took a look again at surgeries that involve labral repairs. And so when the labrum is torn, oftentimes what they'll do is they'll shave out that piece of the labrum that's torn. And at the same time, the biceps tendon actually attaches to that labrum, oftentimes at the spot where it's torn. And so they'll do what's called a biceps tenodesis, which is where they remove that portion of the biceps and basically attach it at a different part, a little bit more lateral. And so, again, another British Journal of Sports Medicine study showed that there was not a significant benefit over sham surgery for patients with those labral tears. Next slide. So I'll let one of my colleagues pick up here and talk about some of the other options in the regenerative field.
So the first thing I'll talk about in the regenerative field is PRP, or platelet-rich plasma. And I think anyone who's somewhat familiar with regenerative medicine usually has heard of this. So typically, normally in your bloodstream, you have red blood cells, white blood cells, and you have platelets. Platelets are there to help with repairing injury. So when you have a wound, a cut in your skin, the platelets get there first and they form that clot. They pull that tissue back together and reorganize it. They also send out signals, growth factors. They release them from the platelets to increase blood flow to the area, to stimulate cell turnover, and really they orchestrate that whole wound response. The method of platelet-rich plasma involves harvesting that power of these platelets, drawing a patient's blood, concentrating just the platelets, getting rid of the red blood cells and the things we don't need, and then injecting those highly concentrated platelets in areas of the shoulder or a different part of the body that need help with repair. And that's what we call our PRP, platelet-rich plasma. Another option that we have is bone marrow concentrate. So platelets have growth factors and the ability to help repair injury. Bone marrow concentrate has all of those things as well, including platelets, but it also has mesenchymal stem cells. And those are very potent when it comes to the repair process. Where platelets can recruit local stem cells that are already in the tissue, we are able with bone marrow concentrate to actually put those cells where we need them. So mesenchymal stem cells are somewhat specialized in the fact that they can differentiate into specific types of tissue. And these are the types of tissue that we would need, such as tendon, cartilage, bone, ligament. So when we have larger tears or more significant arthritis, bone marrow concentrate is a really good option. Another choice we sometimes use is what we call MFAT, so microfractioned adipose tissue. And adipose tissue is fat tissue. This has a different type of stem cell inside of it, and it is different or helpful in a different way. Now, the adipose tissue, as you can imagine, is more viscous and denser. So it's really helpful when we have a large tear, such as a big gap in a rotator cuff tendon, to include MFAT or fat tissue, because that dense tissue acts as a scaffold to help fill in that gap, help keep the healing cells right in that area, so that they're able to do a better job with a bigger tear. Can do the next slide. We have a couple of pictures here of injections with these regenerative products that I was talking about. This here is on the left, we have the rotator cuff tendon on top via the ultrasound. We use always ultrasound or x-ray or both to precisely inject these regenerative products where we want to put them. So we have rotator cuff on the left, and then on the right, there's an x-ray image of injecting into the labrum. Next slide. Here's another picture of the rotator cuff. So on the bottom, you have two ultrasound images. You can see on the right side, it's more obvious that there's a defect in the bone underneath the rotator cuff, which we call a cortical defect. You see that often underneath a tendon tear because the tendon's not attached as it normally would be. The bone's not getting the same stimulus it normally gets. So you can see the small tear on top of that cortical defect. Now you can see what Dr. Torrance is tracing out, the rotator cuff tendon in the ultrasound image all the way to the right side. Dr. Pappas there is injecting a rotator cuff tendon under ultrasound guidance. He can watch his needle go directly into that tear, directly where he wants it to go.
Very happy with my tracing right now.
That was nice. Next.
Hold on. Here we go. Here's the healed picture.
No, this is the video of the procedure.
Oh, video.
Injection, the needle.
Oh, hold on.
Not sure if it'll play. Not on this.
Okay. Hold on. I don't think it will. But what I was drawing is that, so what will happen is, I'll put the drawing in there. So what's going to happen is a needle would go right into this space right here, and you'd see a filling in of this spaces in here. And that's how the cells get into the right place. That good? Clear all my drawings. Next page. All right.
All right, I'll pass it on to Dr. Lieber to talk about some studies.
Okay, let's see. This particular study is entitled The Effectiveness of PRP Injection in Rotator Cuff Tendinopathy. And it's a review of a lot of different studies of well done randomized controlled trials. And at the bottom, you could see that the results showed significant long-term pain relief. Yeah, that's the main finding of the study here. So that's let's go on to the next one. I think it's probably more interesting. This was a study done by Regenix in Colorado, where they looked at 51 patients who had rotator cuff tears. And in this case, they used bone marrow as a way to try and heal these tears and alleviate the pain and so forth, as we've discussed. And this is a study I quote frequently to patients. What we see here is that the results tend to be quite good over the long term. I'll see what was written on the side. Significant improvements in pain and function with the bone marrow group as compared to an exercise therapy group after 3 months. And I don't know if it was in this study or the follow-up to this study. What you ended up seeing was actually closer to like an 89% improvement in terms of pain at the 2-year point at the end of the study, which was excellent. They did show that a majority of the MRIs did show improvement in healing of that tear or filling in of the tear. So this is a pretty substantial study in terms of its importance to how we perceive the results associated with rotator cuff treatments. And it is in close line with the registry data that we have. In other words, we collect clinical outcomes with all the patients who agree to participate in a national database registry. And from there, we can also see what kind of outcomes we're having. And that's really a critical part of Regenix, is that collection of data. And that correlates very well with this randomized control trial that was done as well. So we're really happy with the long-term results. And even in the short term, it's a quicker result than you would see typically with a surgical procedure. Go ahead and next slide. And this was a different study, was done by a different group where they used the fat product that Dr. Velastro was referring to, the microfragmented adipose tissue, which there are some subtleties in terms of what we're allowed to do and not allowed to do according to the FDA. And this is something that we believe is allowable, is to use the fat in this particular way. And in this case, those results are tiny from my eyes, but we're seeing someone read the statistics for me on that, because
Sure. So basically the pain and function score were improved by 80% in the pain and 77% in the function, respectively. The MRIs showed that basically the volume of defect significantly decreased by an average of 90% when they did follow-up MRIs. Arthroscopic examination demonstrated that the articular and bursal-sided defects decreased by 83 and 90% in the high dose groups and the mid and high dose groups, respectively. So in this study, they went in surgically afterwards to look at how the rotator cuff tendon looked after this type of procedure, and 83% improvement and 90% improvement in the mid and high dose groups.
Yeah, that's a pretty substantial result. And there are times we use the MFAT, or we'll use a combination of MFAT with platelets or MFAT with bone marrow can be another option. Let's go and see what the next slide is. These are some images of the same tendon, same person, trying to get the same exact image. On the left is the tear, which is would be considered to be a high grade, very substantial tear. And then there is some filling in of that defect noted 3 months later. I typically will tell patients, we don't really track the tears on subsequent MRIs because insurance really doesn't pay for that kind of thing. But if you do, you kind of want to wait longer than 3 months, usually about a year. I believe it was about a year in the Regenix study where they re-MRI'd the people and saw the changes that occurred. Ultimately, the goal is to improve your pain and your function. What it looks like is less important if you're able to do the things you want to do effectively. Next slide. Similar huge tear on the left where it says original, that black area is this, depending on looking at it from a different angle, this may be considered a full thickness tear. And then the subsequent 9 months later, that hole is filled in. It's impressive result, and then clinically the patient was likely doing much better much earlier than 9 months. It's usually going to be recovery is an important thing to discuss here. It is much easier recovery than surgery, but it still can be a difficult recovery in the first couple of months, maybe in the first month or so. But usually we're starting to see clinical improvements. That is, the patient's feeling better than usual, starting somewhere around 2 months, 2 to 3 months with shoulders is what I typically see.
So that particular patient, they had 100% resolution in their symptoms, and 9 months later they came back to the clinic with another issue, and we figured while they were there, let's see how that tendon looks, and so we saw that it had healed, and we're very happy.
Yeah, that's great. It's a great visible result too. Okay, Dr. Torrance usually handles this part.
Yeah. So we are at the conclusion. We take questions. I like to be the MC of this whole thing, and I get to dish out the questions. So when people ask some questions, let's see what we got coming up. Anybody got some questions for us? One of the questions I want to ask is so I know we looked at a lot of rotator cuff tears here. What study would you guys quote, or what study do you quote for shoulder arthritis?
I usually refer to our registry data because we have a fairly large data set there. I don't really know of any randomized controlled trials of bone marrow for shoulder arthritis. That may exist. I just am not aware of it off the top of my head. But the registry data, if I am remembering correctly, shows at least an average improvement of 60 to 70% in terms of pain and function after a procedure. And those include patients who have really severe arthritis. Sometimes we see a fair number of patients who have something called end-stage glenohumeral joint arthritis, which is just really bad, where the ball in the socket is basically almost merged. There's very little space left. And with certain techniques, and I've been fairly impressed with how well this can work in a fairly large subset of those patients. At least work well enough that they can prevent the need for that replacement and be able to function well enough in their lives. Given the severity of that, I think it's pretty impressive, because the shoulder replacement's a big deal. It generally is a good surgery, but there are issues that can occur with it.
Right. So how much of these, the first question, Dr. Pappas, why don't you answer this question? How much do these procedures cost? And do these procedures in California? You can answer that.
Sure. So the cost really depends on what the treatment entails, and things can be very simple and range to fairly complex. And so the first cost consideration is kind of what is the ammunition that we need to do in order to get you better, because platelets are going to be cheaper than microfractionated fat, which is going to be cheaper than the bone marrow. And then is there a component where we need to inject bone? Are we combining different options? And it depends a little bit on on how much is involved in each procedure. For platelet-based procedure, somewhere between 1800 and 2000, maybe for a simple procedure. For a microfractionated fat procedure, it may be around double that, somewhere in the area of 4,000. And then for a bone marrow procedure, depending on everything involved in that, may be anywhere between 6,000 and 8,000, something like that. But again, it depends a little bit on what we're talking about. And yes, there are Regenexx clinics in California. There's a number of different options depending on whether you're in Southern California or Northern California. If you have a specific question on, and you can tell us where you live, we know a few of the docs out there and can give you a recommendation.
Absolutely. I'm going to ask this question to Dr. Velastro. Since your imaging equipment is so detailed, why is it necessary to perform an MRI?
That's a good question. So we can use diagnostic ultrasound during our evaluations, which is very helpful and very detailed. And that shows soft tissue really, really well. The ultrasound can't penetrate bone, however. So when you're looking at the shoulder, the labrum, for example, we can see kind of a peek into the labrum in a couple different spots. However, that goes throughout the entire ball and socket joint. So we can't always see the entirety of the labrum. That's something that sometimes we can see better with an MRI. Also, sometimes when we have significant arthritis, we get what's called bone marrow edema, so swelling in the bone on either sides of the joint. And the only way we can really see that is with an MRI. So if arthritis is a component of what's going on in your shoulder, an MRI is going to give us insight as to how the bones look deep inside and whether they need to be included in part of the treatment.
Great answer. Dr. Lieber, I'm going to let you answer my friend's question because I know what I've told him. So I've had 2 labrum repairs, one in 2003 and one in 2007. I now have a degenerative labral tear, and I've talked with Dr. Ron about getting his this fixed using regenerative techniques instead of traditional arthroscopic labrum repair surgery once again. Could you go into detail about how you could help? Thanks a ton.
Okay, so you it sounds like you have not had a regenerative injection yet. You've had 2 labral repairs. There's a lot of details here that I would need to know more about. Degenerative labral tears may or may not be actually a source of pain at all. So we just need to sort of determine that. Oftentimes they're not. They go along with just the aging of the joint, or if there's some arthritis in the joint, you'll also see labral degeneration. Sometimes repairing that, or repairing in quotes, that is not necessarily going to change anything. So there's likely other things going on besides the labrum. There's probably arthritic issues and maybe rotator cuff issues. The idea is we don't really only target one structure when we're doing a joint. We're actually trying to address the whole function, stability of the joint, the strength of the tissue. We really want to get a global treatment of that joint, of course, focusing on the areas that are most abnormal or weakened, like the labrum. So we would be targeting the labrum. Of course, we could do that with both ultrasound and live X-ray in combination, as we showed in the pictures earlier. We can easily access the labrum and inject it, and it can certainly strengthen, thicken, and improve its quality and kind of strength of that tissue. So we with these techniques, we're able to help with that. We would not expect your shoulder to ever look normal like it did when you were 20, for example, but we would be improving its overall function and pain and health of that joint. So that's kind of sort of a general description of how we would approach it without knowing more details.
Bottom line, come in, see me for the eval that we're supposed to have, and then we can go from there. Thank you, Dr. Lieber, for giving him that. So great question here. I'll take this. If a person is on very limited retirement income, how will it be affordable? Well, our group's the only one in the world that's starting to get self-funded insurance coverage for these procedures. Why is that happening? It's because our group is the one doing the research, and the results from our patients are what is causing these self-funded companies to come on board. So we're taking everybody's results, we're pooling results. It's called real world data according to Cleveland Clinic. And that's how we're getting insurance companies to come on board. And so with a limited income, you might only need a PRP procedure. We do have care credit to help with anybody who has a limited income. We want to help all of our patients get back to doing what they love. And so whether we're trying to push it on both sides, we can give you some financing options. We're trying to get more of these covered by insurance, and we're doing everything we can to help you. So that's how we can do that. I got a question from, what is the outcome when there's serious tendinosis in the shoulders? Dr. Velasquez, you want to answer that live?
Yeah, so I would say this is similar to the study that we shared with PRP for tendinosis. Tendinosis is disorganized tendon as opposed to a tendon tear. So we have really good results when it comes to improving pain and function with tendinosis because those tendon fibers are still in place. We can help reorganize them and reduce the inflammation and the pain from the tendinosis. And the study there showed that there was long-term, 6 months and greater of pain relief after doing just a simple PRP injection. So I'd say overall tendinosis, we have really good results.
Great answer. Dr. Lieber, as we get older, is it common for you guys to do PRP or stem cell on more than one location in the shoulder, such as the labrum and the rotator cuff?
Yeah, so pretty much on all patients we're treating the shoulder, we'll be treating multiple different structures in the shoulder. I don't know if your question is specifically asking if we would use PRP or stem cells. We could use either one. It just depends on what condition and the severity of that condition. So those would be the factors that we would determine. As you get older, if we're going to use a PRP, we have data showing that we need to use higher concentrations of that PRP to get more growth factors into that tissue. And that is really something you can't do outside of Regenix because it's just sort of one size fits all products that come out of these centrifuge kits. But we're able to customize that and personalize that and make that a much higher concentration to address the aging of that tissue better.
Great question here. What are your thoughts about posture correction oriented physical therapy prior to procedure to improve scapular stability? I'll answer that question. Thanks for asking the question. I've got to talk to my colleagues. This is a clinician that I need to talk to you all about. He has some posture stuff. I think posture is huge. I think that a lot of times shoulder issues come from posture. I think that sixth scapula syndrome is a real thing, and I think that we can all benefit from posture correction, in my opinion. Dr. Lieber, Dr. Velasquez, do you see any different in that?
No, it's clear. I mean, scapular dyskinesia is kind of a disconnect between the motion of the shoulder blade and the motion of the humerus, and that does create an impinging kind of motion and onto the rotator cuff. So yeah, it's always part of the strategy. Often we do it afterwards, or a lot of times people have already done physical therapy before coming to us. It's just I think at this point most good physical therapists are quite well trained in being able to help with that kind of a correction. It's pretty standard for shoulder rehabilitation. So yes, it needs to be part of the program. We don't advocate just sticking this material into the tissue. It needs to be done in combination in a more holistic way, and that's part of it.
Okay. And then Dr. Velasquez, can you explain how your approach addresses arthritis-driven impingement without having to remove the arthritic material at cause for the pain and reduced range of motion?
Yeah, so if we're talking about arthritic material in the sense of osteophytes, so bony overgrowth, sometimes when arthritis is significant, we will get that bony overgrowth as the bone tries to change shape and tries to create more surface area as it's feeling more pressure when the cartilage is worn out. We can't actually physically remove those osteophytes. You can only really do that with a surgery. So there is some limitation in range of motion that comes from that bony resistance that we can't change. There's also sometimes limitation in the range of motion from the inflammation in the joint space or tightness of the joint capsule. Those are things that we can improve while we can't change the bony resistance. So for those types of arthritic shoulders, we can help with the pain, the inflammation in the area, and help somewhat with the range of motion, but it wouldn't be full range of motion because those osteophytes do limit the range in the shoulder.
All right. And I'm going to elaborate on that a little bit. If it's severe arthritis where you're having impingement and That's one thing. If there is a chromium, and that's another thing. I think the acromion impingement is a lot of times a result of poor scapular activation and poor scapular range of motion, in my opinion. So I think there's a couple things to unpack there. If you care to, you can email us, contact us at any time here, and we can talk more. I have more than one bad joint, shoulders and back. What sort of time frame between treatments is recommended? Can the bone marrow extraction be done only once, or is it required each time? So, Jason, I'll answer this question if you don't mind, Dr. Velastro. So, shoulders and back. A lot of times, this is a shoulder lecture, but most of our back procedures are done with platelets. I'd say 90% plus of our lumbar spine and cervical spine and thoracic spine procedures are platelet based. So if we have a shoulder and a back issue, a lot of times we can do those together depending on the severity of the shoulder issue. So that's how I would approach that. Dr. Velastro, would you approach that any differently?
No, I don't have the same thing to say.
Okay. And last question, we both gotta get on to patient care. What recommendations do you have after getting a shoulder procedure done during the recovery to avoid slowing the healing process? Seems hard to live on one shoulder.
There's a short period of time where you're going to have a lot of pain and inflammation where you can't really use that shoulder, but it's a short period of time. We want you to start moving that shoulder pretty soon after the procedure and getting into physical therapy about a week after the procedure. You are still going to rely on the other side for a bit of time, a couple of weeks, maybe up to a month, much less than you would have to after a shoulder surgery. But we do get you moving sooner than you would otherwise with a surgery. We tell you to listen to your body. So as you're recovering and you're building strength back in that shoulder, if you're bumping up your pain more than 2 points on the pain scale than the baseline, we say that's a little bit too much stimulus for the shoulder, and then to back down on the activity. We do want a little bit of stimulus and a little bit of increased sensation in that shoulder to help with recovery. But your body is really smart and gives you that feedback. If you're doing too much and feeling too much pain, then that might slow the healing process, like you mentioned there. So we just say to take things gradual, a little at a time, and listen to your body. And that gives you the best chance of the best recovery.
Bingo. Couldn't say it better myself. Dr. Velastro, thank you for taking the time. Thank you, everybody, for coming today. Again, Sarasota, Tampa, St. Pete, and Orlando. Hit us up if you want to schedule an eval. Otherwise, give us a follow on the Twitters, on the Insta, any of the things above. And we shall talk to you soon. See you in the office. Have a great one.
Bye.